Good afternoon, ladies and gentlemen, and welcome to our 28th episode of the RSM's COVID-19 series, which is for health professionals by health professionals and designed to give healthcare workers on the front lines regular and easy access to updates from healthcare leaders on COVID-19. Today's webinar is focusing on cardiovascular medicine and the effect of COVID. I hope to explore aspects of the disease process, advice for patients at risk, and some of the challenges in the recovery plan ahead. There is a Q&A function that you as attendees can use to ask questions, and I'll try and take some of those during the session. Today, we have some high quality guests, and this includes Professor Richard Schilling, President of the British Heart Rhythm Society, a notable electrophysiologist and clinical director of the Nightingale unit. Dr. Sam Mohiddin, an expert in inherited and acquired muscle disease, as well as an expert in cardiac imaging, most notably cardiac MRI, both who are at Bart's Hospital, London. And finally, our own Sukhjinder, who is our cardiology section president-elect and an interventional cardiologist at Chelsea and Westminster and part of the Imperial Group. Thank you and welcome, gentlemen. I thought that I might just start off asking questions around cardiac risk. And Richard, one of the questions that was posed is there an increased risk for patients with arrhythmias or Brugada syndrome with COVID?
Well, it's a difficult one. So the common question I'm asked is, does AF put you at greater risk of COVID? And there doesn't seem to be any evidence for that. Brugada syndrome, just to remind the audience, is a very rare syndrome where you have a sodium channel abnormality that produces a sort of fairly typical ECG pattern with bundle branch block and ST elevation. And that can make you vulnerable to fatal cardiac arrhythmias. And one of the triggers for the exacerbation of Brugada seems to be pyrexia. And so the theory goes that if you get pyrexia with COVID, are you more at risk of fatal arrhythmias? And at the moment, no one really knows. So our advice to our Brugada patients is to shield as best you can. But the reality is, if you need to work and you need to go out and earn a living, then probably the risk posed by the COVID is still not much greater than someone that doesn't have Brugada. We just don't know the answer to that. But obviously, if you get a pyrexia, you ought to be in hospital on monitor and have that pyrexia controlled as best as possible.
That's very helpful. Thank you for that. And Suki, what about our patients who, two aspects, either for percutaneous coronary intervention or for bypass grafting? What do you think the risks are there for our patients?
Thanks, Nick. So certainly those patients that have coronary disease and have got blocked up heart vessels, who've needed treatment with either coronary stenting or bypass surgery are at elevated risk should they contract the virus. The presence of these conditions doesn't necessarily mean they are more likely to pick up the virus. That transmission will always be determined by their length of exposure to someone else who has it, whether they've been coughed on directly. So it's not that having a heart problem increases your risk of acquiring the virus. What it does do, however, is appear to increase the risk of cardiac complications once you have the virus and you have the illness of COVID-19. What we have seen, and this you must bear in mind that we are looking at predominantly hospitalized patients, so those patients who are less well and have needed to come into hospital, is that they are much more likely to manifest with cardiac issues during their COVID illness. And that seems to be manifest mostly by a rise in cardiac enzymes. The one that we typically measure in the modern era is troponin. And troponin elevation is incredibly common in those patients with COVID-19. The way we interpret troponin rise, really, it depends on the context. Those patients who have chest pain and changes on an electrocardiograph and ECG are those patients who are typically having an acute coronary syndrome, a type of heart attack. But those that have a silent rise in troponin may not, and it may be what we call a type 2 myocardial infarction heart attack. This is where there's a mismatch in the amount of blood that's being supplied to the heart versus an overall systemic illness. Now, this is common to us. We see this all the time. This is not unique to COVID-19. We've seen patients who have influenza or pneumonia or any other cause of sepsis have these troponin rises. But what we do know is that the elevation of troponin does increase the risk of harm in these patients. And all the study data from both China and in Italy and Spain, which have published on these data and it's been available to us to read, shows that those patients are much more likely to have poor outcomes. By that I mean significant heart attack or pass away whilst an inpatient. So that's certainly a concern.
Good, that's fine. So I guess that takes us on a little bit to ask Sam around this sort of silent heart attack or this troponin release. Apart from the coronary side of things, have you had any experience with patients with troponin release who don't have heart attack?
Thanks, Nick. Yes, I think it's important to say that elevation in troponin is really common in COVID patients, and Sukhi touched on hospitalized patients, and in groups of patients who are hospitalized with COVID, usually for respiratory symptoms, about 20 to 30% of them will have elevation in cardiac troponin, and it's really clear that the elevations are associated with more severe disease. Troponin elevation marks patients for poorer outcomes. In some series, the mortality is increased up to about tenfold over those that don't have increased troponin. And critically also, that the elevation in troponin is independent of other pre-existing cardiovascular conditions. So it seems to tell us a truth about the severity of the illness. Another key question, and one that we haven't yet been able to even begin to answer, is whether in addition to short-term outcomes, these elevations in troponin are associated with poorer longer-term outcomes. And for example, there was a signal for poorer longer-term outcome in SARS-1 and in MERS. And I think that the answer to that question, or those questions, will depend on the question that you've asked, i.e., why is the troponin elevated? Sukhi's touched on the common finding of elevated troponin in ITU patients with pneumonia or pulmonary emboli. And I think when I'm evaluating a patient with COVID with an elevated troponin, the first question I have to ask, the first question that's important to ask, is whether or not this is an infarct. And the infarcts can be either due to pre-existing lesions, and the inflammatory milieu in COVID has pre-exposed to the development of an ACS. We've seen lots of patients who have smooth coronary arteries but have developed thrombotic occlusions, either because of embolic disease or because of thrombi that form in situ in the coronary arteries. In patients with severe COVID, at least 2 of 3 Virchow's triad are abnormal. There's a hypercoagulable state. And we believe that COVID the virus can directly affect endothelial cells and damage those. And of course, as Sukhi's also touched on, there's the possibility of the type 2 myocardial infarct, hypoxia, hypotension, and so on. So because we can do things about acute coronary occlusions, I think that it is the important question. However, the majority of patients who are evaluated for elevated troponin in this context don't have demonstrable angiographically evident coronary obstructions. And here we start to wonder whether there's a direct or indirect effect of the virus on the heart muscle to cause the injury, either from the virus itself, a cytopathic effect. The receptor for the virus is present on myocardial cells, the ACE2 receptor. And so some of the earlier questions are as to whether or not there was a direct effect of the virus on myocytes. In actual fact, nobody has really demonstrated good evidence of the presence of virus in cardiac myocytes. So it seems unlikely that there's a direct viral cytopathic effect on the heart. We also now appreciate that many of the complications in COVID are due to abnormal immunology, either in the way of what's been described is often described as a cytokine storm. And we know cytokines can have effects on myocytes and on the heart and cause myocardial injury, impaired LV function. And in several patients, in many patients, the troponin elevation mirrors what's happening elsewhere, and almost certainly this cytokine storm affects the heart and to cause injury. Finally, another possible cause of myocardial injury, and one that I'm particularly interested in, it's a research interest of mine, is whether or not there are abnormalities in adaptive immunity which are triggered by COVID. And here, the presence of autoreactive T cells and self-reactive B cells and antibodies are interesting. And the literature in the last few months has demonstrated that in children, a form of Kawasaki disease is occurring, and I think there's a similar effect in adults. And some of the myocarditic patients that we've seen are presenting a month after the original infection, suggesting that it is a similar mechanism here in adults. Does that answer your question, Nick?
So, yeah, very thoroughly. Thank you, Sam. I mean, there's a multitude of factors, and I guess what we're concluding to is that if you have cardiovascular disease, it doesn't put you at more risk of having COVID, but if you get COVID, you're at higher risk of a complication. And the troponin rise presumably is all due to muscle damage rather than other mechanisms. And then you've alluded to a cytokine storm. And I guess one of the questions really, and I might put that to Richard first, is about any evidence around treatments for COVID or cardiovascular disease and COVID. Is there anything that you've found that's been successful in your own institution?
No, I mean, I think that the only things that have been proven are already well known, dexamethasone being the obvious one. The big challenge that we have is we know, as you've alluded to, the cytokine storm causes a very raised thrombogenicity in the patient. And then the challenge is how much you anticoagulate them to try and reverse that. There's also some anecdotal evidence that patients will have a problem after discharge, and so sudden death a month after discharge is something that has been reported. And whether that's related to pulmonary embolus or cardiac arrhythmia, no one knows. We do know that patients have a tendency to ventricular arrhythmias during the acute phase of the disease, and that seems to be correlating with the troponin, and so it's probably directly related to muscle inflammation and damage. Interestingly, atrial fibrillation appears to occur much less frequently than one would expect in this type of situation. So in the ITU, in an inflammatory infective condition, you'd expect a new AF rate of around 40%, and in COVID, in our experience in our institutions, it seems to be around 16 to 20%. So we don't really understand what's going on there. So I think that the final dilemma we have is the patients with atrial fibrillation. Do we anticoagulate them, and what do we anticoagulate them with? And sometimes we've seen patients on heparin have death because of cerebral hemorrhage. And on the counter of that is that we know that stroke and pulmonary embolus is also incredibly common in these patients. So it's a very difficult condition to manage.
It seems very challenging, and you brought up a couple of things that we could pick up on, I guess. I mean, sudden cardiac death. So I might ask Suki about, I mean, there's a lot of, certainly in the early stages, a lot of patients didn't come to the hospital. And there are reports of out-hospital cardiac arrests. And what do you think the impact's going to be of all these patients who haven't come into the hospital?
Well, that's a huge question, Nick, because this is something we're just beginning to learn about now. The data out of Italy is very clear. There was a huge reduction in the number of patients presenting with ST elevation myocardial infarction. That's a classical myocardial infarction where an artery has blocked completely. There are significant changes on the ECG and is life-threatening in the first 24 hours. And if you believe some of the older series, about half of those patients die before they even make it into hospital. What we've seen in the United Kingdom, across London and in other places, is there's been a big reduction in patients attending in with STEMI, myocardial infarction. And this has also been seen in Italy and in Spain. And the reduction seems to be by about 30 to 40%. So this is quite a profound reduction. If you read a series that's published from Hong Kong, they have shown a 90% reduction year on year in STEMI. So if you compare the same month to 2019, there was a 90% reduction. This is huge. So why is this happening? Well, it seems to be because patients are very worried about coming into hospital. They're worried about coming into clinical environments where they can pick up the virus. And they're also very worried about seeking healthcare and saturating the NHS. Clearly, much of the advertising and branding has been to protect the NHS. And so naturally, people have been trying to avoid using health services unnecessarily. And because some symptoms of myocardial infarction can be a little vague, there is a general chest discomfort, and lots of people misinterpret this as indigestion, then I think people do genuinely miss heart attacks. Although we find it hard to comprehend that as doctors, I think the reality is patients do have this. And I treated a patient not that long ago who had sat on his chest pain for 4 days before coming into the hospital, and he'd got complete thrombotic occlusion of his LAD and his right coronary artery, and it was amazing that he was still alive when he came in. He didn't look very well, I can tell you that, but so patients are avoiding it. Now, if we look at the Italian data, and if we have had a similar reduction, I believe that the BSIS data set, so that's the National Registry of all heart attack, is going to be published pretty soon. If the data shows a similar reduction, then I bet we will also see a similar increase in out-of-hospital deaths. And I suspect that's what we're going to see. So in Italy, the reduction in MI presentation was mirrored by a significant increase in out-of-hospital cardiac arrest. Now, not all cardiac arrest will be due to a classical heart attack with thrombosis. Some of them will be due to other reasons. And as Richard and Sam have already mentioned, there is a higher risk of VF in patients with COVID-19. And so some of those deaths will not be classical MI, but it fits. Those patients who haven't died and have had complete infarction will then suffer the mechanical complications of heart attack that in modern practice, certainly in the United Kingdom, is not common. So we've certainly seen patients who've had very severe MIs that have had then developed a ventricular septal defect. I've seen 2 of those. We've also seen patients who've then had very severe circumflex infarcts, caused severe mitral regurgitation due to flail leaflet and papillary muscle rupture with frank pulmonary edema. Very unwell patients need urgent surgical treatment, and unfortunately with poor results. So I think that those are the kind of complications that we will have seen over the last few months. As lockdown has lessened and as our experience has changed, certainly in London, we are now starting to see a more normal pattern of presentation of MI. But I suspect what we will see over the next year or so are patients now presenting with heart failure, which tends to present more insidiously, and that's because they've had damage to part of their heart muscle, and now then the muscle can no longer cope, and then they present with breathlessness, fatigue, and ankle swelling over a period of time.
That's really, really helpful, and it's a lesson for the future and a problem stocked up for the future, isn't it? Sam, one of the questions that's been raised is around patients with inherited and acquired muscle disorders and HOCM, let alone the group with diabetic cardiomyopathy. Is there anything that you've got or any experience you've had with that group of patients?
Yes. Well, we've taken an approach to advise our patients with inherited and acquired heart muscle disorders to stay away, to shield, those individuals who have developed COVID have had varying severities of complications from COVID itself. But I think what will become critical in understanding what the risks to patients with that form of cardiovascular disease is understanding the mechanistic links between having cardiovascular disease and having more severe COVID. I don't think we understand what the mechanistic link between pre-existing cardiovascular diseases and outcomes is, because the outcomes aren't always cardiovascular.
Okay, that's very helpful again. Richard, there's a lot of email traffic around patients who have out-of-hospital arrests after they leave. So I think there's a lot of concern whether, are there any factors one can use to predict which patients might have that? And then there's quite a good comment, is it worth issuing them with a life vest?
Yeah, so I think that the incidence is still low. It's still anecdotal, and it seems to be something that of people that have survived ITU, long ITU stays. So I don't think it's something that we would, at the moment, we're not seeing a signal that these patients are at very high risk, but we are seeing the odd anecdotal story of patients who appear to have survived the severest part of the disease and then dying after discharge. But it's certainly not something that we would recommend issuing life vests, or indeed, I'm not sure there's any way of risk stratifying these people easily. The patients who are most vulnerable, those that have had big infarcts, have got structural heart disease, are likely to already have the protection of implantable defibrillators anyway. So I think the honest answer is we can't risk assess those patients, and it's a relatively low risk, but certainly something that is worth exploring further, particularly as this disease drags on.
Okay. I think if I'd ask you another question, and your other role, really, I mean, it is a really an update, and as many of us know, you were clinical director at the Nightingale Hospital. Any update on what the Nightingale is being used for and what it might be used for in the future? And I guess my first question is, I mean, what was a major lesson that you learned from the Nightingale experience?
Well, I think I think it's a lesson that was learned throughout the NHS, actually, that if you let clinicians lead, they will often rise to the challenge. And so we just didn't have the capacity to micromanage everyone. And so there was a lot of delegation and trusting people to deliver, and they did. And so a lot of decision making in the NHS tends to be quite stagnant and slow. We'll have all written business cases and then found it takes months and months and months for people to either say no or yes. And so a lot of my colleagues are saying, why can't it always be like that? So that's probably the first lesson we learned. The Nightingale is basically a warehouse with a concrete floor. So it's ideal for patients who have ITU because they're lying in a bed and they don't need toilets and showers. It's less well suited for patients who are conscious, who need all of the hotel facilities that we would normally provide in a hospital. So I hope that Nightingale won't ever be used again. If it is, then that's bad news, something badly has gone wrong. But I think if it is used again, what it should be used is for ITU of every single COVID patient in London, because one of the disasters that we faced, as Sukh implied, is that all of normal elective work is shut down. We've got a massive backlog of work that will probably miss some patients, we'll never get through them. And so we shouldn't be using ITU for COVID in normal hospitals. We should be doing all of the COVID care at the Nightingale. The results of the Nightingale will actually be very similar to ITUs around London. So we've already proven that we can produce similar outcomes in terms of mortality. There are some things that we couldn't do, like ECMO, but by and large, we shouldn't be using normal ITUs for COVID. They should be doing their normal elective work and allowing London and the NHS to keep going as normal.
That's really helpful. Now, we may touch on the recovery question towards the end. There's a lot of emails around questions around hypertension. Twofold. One is the risk in patients with hypertension, and secondly, the value of ACE inhibitors on managing patients with COVID. Sam or Sukhi, does one of you want to take that one on? That'd be a no.
So I'll mention a few things. So the first thing to say is that hypertension is a risk factor for cardiac complications, and it's been shown in a number of series across the world, and it's what we've also seen here in the United Kingdom. So it doesn't necessarily mean you're more likely to pick up the virus, it just means you're more likely to have more complicated COVID illness, particularly those who are hospitalized. The treatment of hypertension, i.e. that, is your blood pressure well controlled versus not well controlled, I don't think is a particular driver for the risk. It's just the fact that you've got hypertension, and I think that keeps coming through time and time again. If patients have got a COVID illness and are unwell and their blood pressure is particularly high, then it makes sense for us to treat that blood pressure, because very high blood pressure will risk stroke, whether it's ischemic or hemorrhagic. So that's an important factor. And so I don't think that that's a major concern. The ACE inhibitor story is complicated, and I will give you my take on it, and I will hold up my hand and say this is evolving. The take-home message of it is that there was concern that ACE inhibitors would increase your risk of a COVID illness because the virus enters cells via an enzyme that is partly upregulated, the ACE2 enzyme that's upregulated in patients who are taking ACE inhibitors. Whether this causes an increased severity of illness is less clear. Small studies from the Far East suggested this may be a factor, but when you take a deep dive into some of those studies, I think some of the statistics were not well done. And when you factor in patient age, that seems to remove some of that risk. There was a publication in the New England Journal of Medicine that combined data from North America, Europe, and the Far East, and seemed to suggest that there was no elevation of risk. But my understanding is that there is slight concern because some of the authors of that particular study are caught up in this surgisphere controversy, in which there seems to be some data that was based on kind of computer modeling and not genuine collected patient data. So I have to say, I think that is a little bit unclear. Nonetheless, the European Society of Cardiology, the British Society of Hypertension have been fairly clear and recommended that we do not stop ACE inhibitors in patients who need them. So, and Sam, I'm sure, will speak to this, those patients with a dilated cardiomyopathy need ACE inhibitors because studies have shown if you withdraw these drugs, there tends to be a rebound impairment of the heart function, the ventricle begins to dilate again. And so it makes sense that those patients are most at risk to continue it. If, however, you've got a patient who has common or golden blood pressure and they can have another drug, for example, a calcium channel antagonist like amlodipine or nifedipine, commonly used drugs in primary care, it would be reasonable to give those drugs rather than starting de novo ACE inhibitors. And I think that's my kind of brief upshot of the ACE story. There is an additional caveat to that. There are some studies that suggest that ACE inhibitors may well be protective. This seems to be coming through with the ARBs and also with certain ACE inhibitors. And so I think this is an evolving space. We have to remember 6 months ago, this virus was not well recognized in the literature. So it's a big ask to get massive observational studies looking at these risks out, looking at these factors out in a meaningful way, and for us to trust them. People have moved very, very fast, but it doesn't always mean that the publications are perfect.
Thank you very much. That's very, very thorough. And I know some questions around Entresto as well. So a full combination of ACE inhibitors. There are quite a number of questions going on here, and so I'd like to carry on for another 10 minutes or so. But I'm also conscious that Richard, you have to leave us. Have you any final thoughts before you have to go at all on the whole COVID experience?
Well, I think that we've all found this a generationally defining experience, and I think that it is difficult to know how it's going to end. But I'm optimistic that we'll find a way out of it, and the hard work of all of my colleagues to try and keep elective work going is going to be really important. But I think that government and NHS organisers also need to recognise that those things like cancer, AF, all of these conditions that cause real problems, we need to now begin to prioritise and get those waiting lists down again. I'm also very delighted that I've had 2 colleagues who actually know something about cardiology on the webinar with me to help answer the questions more effectively. But thanks very much for the invitation.
Thank you very much, Richard. Thank you. Sam, there's a sort of a question around late pericarditis in COVID. Have you had much experience with that?
No, not much. We're managing a case at the moment of a late presenting pericarditis, but this is the only case I've seen. Similar cases have been described in the literature, and I think the concept of late manifestations following an acute illness is one that will continue to be unraveled as we know more and as we get away from the peak that we had in March, April. There's lots of pretty convincing evidence, I think, now that the majority of the problems in COVID are related to the immune system, to immunology, inflammation, and this phenomenon of something happening a month after the initial infection is a real one. And I think that the pericarditis story, tamponade presenting a month later, sudden cardiac death, the myocarditis that we're seeing, the Kawasaki syndromes in adolescents and young children may all be part of something similar, and that's to do with an abnormality in the adaptive immune response late on. How we treat it, what's causing it, I think these are also interesting questions for us to try and answer.
Okay, thank you very much for that. That's good. Richard touched upon this really, and I might ask Sukh this about how do we restart our services after COVID? I mean, a lot of resource has gone into COVID, but whether it's cancer, let alone cardiology, there's a lot of work to be done in terms of managing our patients. What can the patient that doesn't have COVID expect going forward?
Yeah, so this is a huge question, and our challenge going forward. First thing to say is that the NHS has coped principally because we've essentially stopped almost everything else, and essentially we have been a COVID treating machine over the last few months, and all routine care was discontinued. There was no elective work being done. Patients were being reviewed in our clinics through telephone or through telemedicine. And now we're desperately trying to restart, and some of us are being a little bit more successful than others, and lots of different plans are coming. And you can already see the machinery of the NHS kicking back in, and it was almost, as Richard was saying, it was almost better when we could take an idea and run with it, and no one was blocking us, and we found that we could execute pretty quickly. As soon as there seems to be a process that the health service kind of imposes, it generally slows everything down. So what we've been trying to do, certainly in West London, is for us to restart cardiac surgery, because we see that as a huge milestone. If we can get our surgeons operating on routine patients again, this is a huge step. To do this, you need intensive care beds and you need operating theatres. And this is a challenge because most of our intensive care beds and operating theatres were converted into ITU facilities for patients with COVID. So at the moment across London, routine bypass surgery is only occurring in a limited number of hospitals, and each case has to be discussed in a multidisciplinary team meeting that's held daily with all the different surgeons of the different hospitals coming together. Now, this is very different when I talk to my colleagues who are in other cities like Liverpool, Manchester, and in the Midlands. What I'm hearing in those places is that they've been able to get their skates on and get working far quicker than we have. I think the faster we get back to providing more routine care, the better it will be for our patients, because what I worry about is patients having major events whilst waiting for routine procedures. We've certainly seen patients who've come in who've been on the list for bypass surgery who then had an acute coronary syndrome. This could have happened at any time, but I'm sure that the COVID component has contributed in some way. And then they, rather than then having bypasses they would have had, then have had to have multi-vessel PCI, which in many situations is absolutely fine and it gives a good short-term result. But some of these situations will mean that they will have had less than optimal care. So I think this is a major concern for all of us. I think what we should do is work together as networks. I think there is a natural tendency to be quite territorial in the NHS. People want to protect their patch, and that's useful in the normal process. But at the moment, what we have to be able to do is move the patients to where the care can be delivered. So some hospitals are being set up as so-called dirty hospitals. These are places who've got emergency departments and then have an unrestricted medical take, and therefore will be having patients with COVID coming into the hospital, potentially making so-called clean areas into a dirty area. Therefore, those kind of centres cannot deliver higher risk elective procedures like bypass surgery. And then there will be other places which are so-called clean sites that have no emergency department. These tend to be typically tertiary centres, and that they can have a control over the type of patients who are coming in. At the Hammersmith Hospital, where I work, they have a fairly complex mechanism for swabbing patients before they come in, period of self-isolation before patients can come in. We're requiring 14-day period of self-isolation. This is difficult for patients. It also means their family members have to self-isolate. They're re-swabbed when they come in. They then have a procedure. They're given a private room. The private facilities of the hospital have been dedicated to being able to provide this service. And then if it's coronary intervention, then they're ideally going home the same day. But those who are having bypass are then treated and having to stay self-isolated for a further long period of time. I think it's more than 21 days. So it's a very long period of self-isolation for patients. This is actually putting a lot of people off. Lots of people are saying that they don't want to have that. You know, we've had lots of people say, thanks, but no thanks, I'll come back once this is all over. And, you know, we've had to have quite difficult conversations with patients, particularly in those with very severe left mainstem disease, very critical valve disease, to be able to convince them to come in, because they are at greater risk of their cardiovascular condition in that situation than they are of picking up COVID.
And that sort of outlines, I think, some of the problems that everyone faces around the interventional side and the continuity of care. Sam, I mean, part of work is not all around cardiac intervention and procedures. It's outpatient care and how we manage that. How have you managed that differently? I mean, patients obviously can't come to clinic.
Yeah, no, the answer that Sukhi gave made me reflect a little bit on the difference between what different types of cardiologists do, and what we're talking about here is both acute services and elective services, and how to catch up as safely as we possibly can, with the risks being continued risks of exposure to COVID and the risks of delayed treatment and poorer outcomes as a consequence of that. So we've got to figure out how to catch up and catch out safely, and clearly how we do these things will depend very much on what it is that we do. So in my world, which is mainly to do with outpatient reviews of patients with cardiomyopathy and also elective tests such as MR, I think what we've learned is the value of remote working, of teleclinics. And one of the benefits, I think, one of the few benefits of the last few months is that we've learned how to do this in a way that's, I think, now pretty effective, and perhaps has accelerated a trend by a matter of years. And I don't think we'll go back to the way things were before. We've also got to start using time and equipment in a different way. So extended hours, so that we can use things that have fixed capital costs, like outpatient rooms and MRI scanners that require deep cleaning, for example. We can use them more effectively over longer hours. And one of the problems that Sukhi also touched on, I think, is really fundamental, and it's changing behaviors. We have to change behaviors again. Patients are scared. Healthcare workers are also scared, and we've got to reassure individuals that our new ways of working are safe and that are iterative. They will respond to changes in risk and in our environment. And that's going to be quite difficult to do, because it will require quite a detailed knowledge of immediate environments and risks. So lots to do, but I think it's important also to understand that, as Richard has said, this has been a generationally defining event, and it will change the way we deliver medicine, I think, and cardiology is no different. Thank
you very much. That's just typifies some of the changes that have gone through in many hospitals with COVID. I think it's a great point to sort of wrap up on, and I really have enjoyed our webinar today. I've learned quite a bit. It's very clear that our cardiac patients are not more at risk of getting COVID, but when they are at risk if they catch it. If they do, the complications are known about, and there are treatment strategies now available. We've learned a lot more. We know to intervene a lot earlier. Our resources have increased, and I'm thankful we didn't have to use all those ventilated beds at the Nightingale. the focus now should be recovering for the rest of our cardiac patients and our general patients as well. And I'm glad to see those strategies in place, and Sukhi outlined those in detail at Imperial. And Sam, I think your point is right, isn't it? It is a generational change. There is a movement to new ways of working, whether it's through digital platforms, not being risk averse in certain instances. A test isn't always the way to go forward with our patients. And so we're going to find a different way of working, perhaps a greater use of clinical acumen, who knows. But I'm really grateful to you and the other panel members for today. I thank you to you from the audience for your questions, and we'll try and answer those ones that we haven't done in one of our other sessions. So I will end by thanking our expert panel. There are, to remind you, 2 webinars coming up. On Thursday, there is a COVID webinar on the human genome. On the 27th of July, a quite exciting COVID seminar with an international faculty looking at 3 different aspects, including cardiovascular aspects of COVID. And those of you who have tuned off, there's currently a congenital heart disease seminar and webinar going on at this time. So with that, thank you very much for joining us, and I wish you well. Goodbye.